Imagine you're 15. Your periods are super painful. You have tried heating pads, ibuprofen, and everything else that you know is supposed to help. You're starting to wonder if something is really wrong with you. You go to a doctor, and instead of being dismissed or automatically prescribed birth control with no follow-up, they say, well, let's just do a quick, painless, non-invasive test and see if you have endometriosis. Then you either get some sticky electrode pads put on your abdomen, or you spit in a tube. No big deal. And then, either minutes or days later, you know with a high degree of certainty if endometriosis is the cause of your period pain. As of this summer, that could be the reality for people living in countries like the UK, Canada, and many countries in Europe. Because 2 different non-invasive tests for endometriosis have hit the ground. And so far, they're looking really good.
What's happening to your body, we don't know, because we've never really studied the female body. Say it's all in my head, but the research is quite spotty. No, we've never really studied the female body. I go to the doctor to get dismissed. Try losing weight, you're just anxious. That's fine, that's cool, I'm not pissed. Just wait 10 years for a diagnosis. Psychosomatic, you're so dramatic. Hysterical, emotional, hormonal, erratic. Heart disease, chronic fatigue, depression and anxiety. Do you have pain? No, you don't, because we've never really studied the female body.
Welcome back to CRAMPED, the podcast where I try to find answers to my and other people's questions about their period pain. I'm your host, Kate Helen Downey. While you're here, if you have not already done so, I would just love it if you would go to patreon.com/cramped and join the Patreon at a paid tier. For just $5 a month, which is cheaper than any drink you can get at any happy hour that I know of, you will be supporting this project and making it possible for it to continue. Plus, we have great perks like a live Zoom chat once a month, voting on episode topics, and at $25 a month, you can even personally assign me a research question. So if you're getting useful information out of CRAMPED, if this show has helped you advocate for yourself in medical situations or informed you of options you never even knew you had for your period pain treatment, go to patreon.com/cramped. So, non-invasive tests for endometriosis? When I started seeing posts about a saliva test for endo, I wasn't sure what to think. It's possible I've become a little bit jaded when it comes to good news in the world of diagnostics for conditions that cause severe period pain. Very often, a flashy headline ends up being a nothing burger that just leaves me even more enraged than I was before. But this time, as I started digging into the announcements coming out of Europe and the UK, I realized this was very much a something burger. This is real shit. So I found someone who has been advocating for these tests over in the UK, and I asked her to just tell me all about them.
My name is Dr. Gail Busby. I'm a consultant gynecologist. I live and work in Manchester in the UK. I'm what I describe as a lifespan gynecologist, meaning I do pediatric, adolescent, and adult gynecology.
You recently gave a statement as a part of the announcement about new non-invasive tests for endometriosis.
Yep, absolutely.
So can you tell us a little bit what's going on in the UK? We over here in the US are watching with bated breath and a little bit jealous because you have new non-invasive tests for endometriosis, meaning in order to get diagnosed, you don't have to get surgery. So can you tell me a little bit about these non-invasive tests?
Yeah, it's really exciting that 2 new painless non-invasive tests have been approved in the UK by NICE, which is the National Institute for Health and Care Excellence. And that's the body that kind of controls what is available on our National Health Service. And these 2 tests, they vary. One is a test that is done on saliva. So it's a kit that you can do at home and send in for evaluation. Yeah. And the other is one that's based on electrodes on your tummy. And I'm sure we'll talk a bit more in detail about both as we go on in this conversation. But yeah, they've been within the past 3 weeks been approved by NICE. So everyone's pretty excited about that.
I just got goosebumps. I love new approvals for tests. Why is it important that we have these non-invasive tests for endometriosis?
Yeah, in preparation for this wonderful experience of being on your podcast, I thought, oh, I'll listen in to a couple of previous episodes. And I came across one where you were interviewing Congresswoman Yasmin Ansari.
Yes.
And I thought what she said at the beginning of that podcast was really incisive, really. She said, I have had debilitating pelvic pain and probably could be endometriosis, but, and I quote, I just have never taken the many, many steps it takes to properly diagnose that.
Yep.
And that's the nubbin of the issue, that diagnosis can take up to an average of 9 years of endometriosis. So the advent of these non-invasive tests mean that more women can be diagnosed more quickly and receive appropriate treatment, effective treatment.
Yeah.
On the other side of the coin, it means that women who are having pelvic pain for reasons that are other than endometriosis, they're not delayed until the actual diagnosis is made. They can be referred elsewhere to be investigated appropriately. So it serves both groups of women.
Yeah, and even if it's not endometriosis, it feels like to me, being not a doctor, that if they can't figure out what else is going on, endometriosis is what they're like, well, it's probably endometriosis, and
it's probably that.
1 in 10 people with uteruses has endometriosis, so a lot of the times it is. But if it isn't that, now we can actually have a test pretty easily done to rule that out, which was pretty much impossible before this without surgery.
Yeah, exactly. That's the whole thing, because surgery is not without risk. And I think that really the patient population really close to my heart are young women and adolescents who have pelvic pain, because this pelvic pain can really impact the rest of their lives. Yeah. Adolescents are in a time of development mentally, physically, socially, emotionally, and having pelvic pain, painful periods, missing school, missing social events, missing sports, it can really have a long-term impact on their life. And however, on the other side of the coin, pelvic pain and painful periods are quite common in adolescence. Mm-hmm. So what we don't want is either delaying diagnosis because no one wants to operate on them, or thinking they have endometriosis when they've got something else. For example, Crohn's disease quite often starts in adolescence. And is it Crohn's? Is it endometriosis? And if we have another tool that means they don't have to have an operation, it's excellent. It's brilliant.
Yeah, as someone who started getting extremely painful periods at 14, that would have made such a huge difference to be able to get a swab test or an electrode test at the doctor and to have them actually be able to tell me what was going on, even if I didn't get surgery at the age of 14.
Absolutely.
I have been doing a lot of reflecting over the last 2 years, a lot of going back and digging through memories that I had really pushed aside that were genuinely traumatic. It was partly traumatic because of the pain, but it was mostly traumatic because none of the adults in my life could tell me what was going on. I went to my school nurse. She didn't know what was going on. I went to my mom. She didn't know what was going on. I went to a gynecologist for the first time. And she just said, yeah, well, some women have painful periods. If at that point I had been able to get a test that had told me, okay, it's endometriosis, here's what we know, here's what we can do in the future, that part of the trauma of just being like, oh, nobody knows what's happening to me and nobody can help me would have been gone. And like, yeah, painful periods are still traumatic in their own way, but taking away that layer of, oh, I'm alone at 14 to deal with my brand new horrible periods. That's scary. And that would have been gone.
It's validation. It's validation. I can't tell you how many young people say, oh, Dr. Busby, thank you so much for listening and believing me. It validates that, yes, this is more than the norm. This pain is more excessive than we'd expect. Let's do an investigation to determine whether you do or do not have it. So it's always, even if it's in a positive test, it's relief because they're like, oh, I've got an answer. It's like what you've just said, I've got an answer. And then you can move forward to managing things.
The answer means something, and knowing that there's knowledge about what you have and there are treatment options, that is a relief. Yeah. So, okay, can you walk us through both of these tests? What are they? How do they work? How do they tell if you have endo from your spit or these electrodes?
Okay. The first one I'll talk about is the EndoSure test. The EndoSure test that's the electrode test. And I always say to my patients, I say electrodes, but don't think we're going to stick needles in you. That's not the way. They're sticky, like sticky pad electrodes, like an ECG of your heart. Okay. And what they do is they pick up the electrical activity from the muscles of the bowel. Okay. Endometriosis deposits. So endometriosis deposits, like endometrium, produces substance called prostaglandins. And
We've gone over prostaglandins
Oh, yeah. You know
extensively on
all
this
about that.
podcast.
Absolutely.
Yes.
Absolutely. So the role of prostaglandins is to cause contraction of the uterine muscles in order for labor or to get the periods out, etc., but also contractions of the fallopian tubes to get the eggs down into the uterus. So that is the role
Oh,
of
interesting.
prostaglandins.
I didn't know prostaglandins did that too.
Yeah. So endometriotic deposits in the pelvis so produce prostaglandins. Yeah. And they therefore have an impact on the smooth muscle of the bowel. Yeah. And two prostaglandins, prostaglandin E2 and FA, they are produced simultaneously by these endometriosis deposits, which is unusual for any condition that they produce at the same time. And what this causes is a kind of spasm of the bowel. So the bowel, usually contractions are propulsive, so it takes food through the gastrointestinal tract. Yeah. But these, the fact that you've got both of them, the effect that they have is that it stops being forward propelling and it just goes into this kind of spasm business.
Wow.
And that's what is picked up on by the electrodes. So it gives you this fingerprint of endometriosis.
I knew that endometriosis very often slows down the digestive tract, but it was explained to me that that was mostly because of the upgrades in the nervous system, so that functions like digestion were deprioritized because the nervous system was in a state of like fight or flight all the time.
Yeah.
But this prostaglandin, like the spasms that are caused by the prostaglandins,
makes sense, doesn't it?
It makes sense. Wild.
Yeah.
And so there's no other situation that results in that kind of spasm of the bowel.
Yeah, so interestingly, the EndoSure test was invented by not a gynecologist, a gastroenterologist. Yeah.
That makes sense.
And yeah, absolutely. And he was testing the pressures inside the bowels of kind of unselected women. And he realized that this pattern was identical or similar for women who have endometriosis. And hence, light bulb moment goes on. And then he developed the external electrodes, which showed the same result. Yeah. And there we have the EndoSure test, and that's how it works.
Wild.
Really clever.
Wild. Yeah.
Yeah.
And it's what we've been saying is that endometriosis is not just a gynecological disease. Endometriosis affects so many systems of your body, and the fact that it's siloed into only being treated gynecologically misses so many of these things. And the fact that this test was developed by a gastroenterologist testing something totally different and found such a reliable, obvious, like diagnostic sign. It's like, yeah, we should all be talking to each other, right? All these doctors and different specialties should be talking to each other because endo shows up in so many places.
And he did his homework because he also did the test on people who have known other conditions like irritable bowel syndrome, Crohn's disease, whatever. No other condition caused the identical fingerprint of that of endometriosis. Gallbladder disease was similar, but he just was more specific in the frequencies he took for the test to eliminate that possibility. So yeah, there you go. 3 little electrodes on your tummy. Yeah.
Is it very accurate? I forget the word. What's the over under on how accurate it is?
So we use the term sensitivity and specificity. Okay. So the sensitivity is how likely something is to pick up condition which you have. Okay. And the sensitivity is 95%. True positives.
True positives.
Yeah. You've got it and we pick it up.
Yeah. So the 5% is the false negatives where you have it, but it does. This test doesn't.
But we've missed
pick
it. Yes, correct.
Got it. Okay.
Correct. So the specificity is the test says you don't have it and you really don't have it.
Okay.
Yeah?
Yes.
And the specificity for the EndoSure is reported at 99%.
Wow.
So if you've got a negative EndoSure test, you probably ain't got it.
Yeah. Wow. Okay. So then only 1% of people get
with a negative test will
actually have it. Okay.
Yeah.
Wow. That's really good.
It's really high, isn't it?
Yeah. Okay. So that's the EndoSure test with the electrodes.
Yeah.
And then what about the saliva test? Yeah.
Yeah. So the endo test is a saliva test.
And this is going to be hard to do over audio because endo test is like the the name of
Yeah.
the test for endometriosis where they test your saliva.
Saliva.
So
Yeah.
there's EndoSure and EndoTest, and they are both
Yes.
tests for endometriosis.
Correct. Yeah, got to have endo in the title.
Go on.
So the endo test, or the ZIWIG, to be complete, endo test is a saliva test. So this is even more technical. So it looks for microRNA in the saliva. Okay, so just to give a sort of brief, not too nerdy. I know you're nerdy, but
We can get nerdy.
stop me if I get too nerdy. So everybody knows what DNA is. Yeah?
Yes.
So DNA is basically your genes forms DNA in the chromosomes. So that's what your DNA is. It dictates the color of your hair, the color of your eyes, etc., etc., etc.
Right.
Everything in your body. So your genes are within DNA. And one definition of a gene is the amount of DNA that will code for one protein. Most things in your body are made of proteins, like enzymes, like your hair, like your skin, the collagen, whatever, proteins.
Right.
So the DNA does not leave the nucleus of the cell. So it needs a messenger to send the information to make the proteins. And that is your RNA.
Okay. Yeah.
Okay.
We're with you. We're with you.
I'm still not there yet. To what microRNA. MicroRNA is a type of RNA that it's a short bit of RNA. It does not code for protein, so it doesn't form part of the whole gene making protein thing. Yeah.
Okay.
But it helps to control the regulation of gene expression.
Oh, sure. Yeah.
So it's like extra stuff just to break, so accelerate, that kind of thing. It influences the genes, how the genes work, basically. And then they are basically leave the cells, booted out of the cells in various ways. They find their way into saliva and blood, etc. So that is what we're testing. These extra little bits of RNA that don't themselves form part of the gene process thing, but can influence them. And they end up in saliva, in blood, in body fluids, etc. That's what we test for. It's a fairly new kind of thing. They were first found in 1990. Which maybe to you seems forever, but not to me, and related to disease processes in the early 2000s. Yeah, there are over 2,500 known microRNAs.
Oh, wow.
And 109 of them have shown to be diagnostic for the endometriosis. They give a signature for endometriosis.
The presence of a certain amount of them indicates endometriosis. And is that because if the microRNA are controlling gene expression, are there certain
genes that are more or less expressed? Yeah.
Okay. So the endometriosis causes the microRNA to express different gene things?
Yeah, I don't know if we know that amount of detail as yet.
Okay.
Because like
we just know that they're
really
present.
New. We know that they're present. So it's difficult. We can try to extrapolate that, but I don't know whether we have that detail of knowledge yet.
So if you have a certain collection of certain microRNA present in your spit, you probably have endometriosis.
Yeah, they call it a signature for endometriosis. So one is a fingerprint, one is a signature.
Is that the same? Because I know that they're working on tests for menstrual effluent to tell if you have endometriosis.
Yeah, blood, menstrual effluent, etc. But I think this is the first one that's been validated as far as I know. But work is ongoing.
Cool. Do you know if the tests on blood and menstrual effluent are also testing microDNA, or are they looking for other things?
I think microRNA, yes, I think they are testing at least for microRNA. Whether other things. They tested blood before saliva, actually. But I think the difficulty with blood is the transport is a bit more difficult. The blood can clot, and that can affect the result. But saliva doesn't clot.
Cool.
But there will be loads of research ongoing in every body fluid, thank goodness.
I hope so.
Yeah,
because this sounds really promising. Exciting and really promising. Yeah. What is the specificity and the sensitivity of the endo test with the saliva?
I thought you'd ask that. Okay. So both tests are really high. The sensitivity for the endo test is 97.3%.
Wow. Okay.
And the specificity, 94.1%. So both like high 90s.
Good. Wow. Okay. Yeah, that seems really good. Okay. And then the endo test, they can send you a kit and you can spit in a tube.
Send you a kit,
and then
spit in the tube. Absolutely. Put it back in the box.
So cool.
Send it back to them. And the results are available. It takes a few days because they've got to amplify it and they use AI, et cetera, et cetera. So you get your result within a week. The EndoSure test takes about 45 minutes and the results are available right away.
Okay. And the EndoSure test, I assume you have to go into an office that offers
You have to go into
that
an
has
office, exactly. The
that has
equipment,
the right equipment.
and someone trained. Yeah, exactly.
Yeah. We're going to take a quick break and we'll be right back. This might be a good time to mention that if you join the Patreon, you can listen to ad-free episodes. Just saying.
'Cause we never really studied the female body.
Welcome back to Cramped. I'm talking with UK gynecologist Dr. Gail Busby about the 2 new non-invasive endometriosis tests that the NHS is making available. The EndoSure test, which uses electrode pads to read the electrical signals coming from your intestines and look for the distinct fingerprint of endometriosis. And the Endo test, where you spit in a tube and they look for 109 types of microRNA that form a signature of endometriosis. So where are each of these tests available? I know you're in the UK and this is all happening in the UK. Is this available throughout the NHS in the UK?
It's been approved by NICE. The intended rollout, I think, begins in October of this year. The EndoSure test was available for example, in private practice, in private practitioners, private hospitals, etc. But NICE approving it means that it is both clinically appropriate enough, safe enough, and the money side of it also tallies up, okay? Because the NHS is free to the point of need, so it means it has to be economically sensible, because a drug is good, someone might invent a drug for cancer that is extremely rare and it costs like 20 million pounds to treat one patient. NICE might say we can do so many other things with that money. It's both economic as well as safety and efficacy.
Okay, so NICE is like the FDA and the board of directors for the NHS.
Okay,
so they decide both
gatekeepers,
is it safe,
they're the
is
gatekeepers.
it effective? Yeah, they're the gatekeepers of what is available through the NHS. Okay, that makes so much sense. Thank you.
Yeah.
So are these tests now available anywhere that has the NHS in the UK, like through any NHS provider?
So they're approved in England in the NHS, and they're approved for a period of 3 years, through which, because they're new tests, we need larger studies, we need more women, we need more data. So they've approved them for 3 years in the first instance, and then I guess it'll be reevaluated after that. In terms of where else they're available, so they have the E mark, and that's the European mark for safety, effectiveness, etc. So they are available pretty much throughout Europe. In most places in Europe, they're available in the Middle East, so the UAE, they're available there. EndoSure will soon be available within the next 3 months in Australia. It's available in Canada, the EndoSure test. So it's slightly variable. So Europe is the common denominator. And then in various places. But, as time passes, I guess more and more countries will uptake.
Amazing. And then I know this is not your area, but I'm just going to ask what you know about it. Can you get either of these tests in the US?
I know the answer to that, I think. So I think that, speaking of the FDA, so I don't think they are available for use in the US as yet. They may be, for example, clinical trials, but in terms of patients, no, not yet. I have found out that the EndoSure test is due for FDA approval in the second quarter of 2027. So not so far away.
So it's coming.
So hopefully
we're just
within a year.
behind a little bit on the EndoSure test, and we're still in limbo on the saliva test.
Yes, I think so. That's my information to date. But I'm sure soon enough.
Wow.
You can join the happy bandwagon.
Sooner or later, we'll get there. And then what gets covered by insurance is a whole other conversation.
There's another story.
Yep. And I won't ask you about that.
Yeah. Please.
Okay. I have a controversial question for you that when I asked my listeners if they had questions about the saliva test, one question came up over and over again because there have been recently published findings that men can also get endometriosis. And the timing of all of this has felt interesting to people. And so I had a number of listeners ask, is it true that the recent finding that men can get endometriosis has motivated the development of non-invasive endo tests.
No, I don't think so, because it may have been popularized recently that men can get endometriosis, but I think we've known that for a very long time.
Oh, really? Okay.
I feel like I've known that for 2 decades. It's rare.
Okay.
It's rare. But yeah, absolutely, it can happen. So I don't think so. Also, important why I told you the genesis of the EndoSure test was that it wasn't looking for endometriosis, was it?
It was a happy accident.
It was looking for bowel. Yeah, it was a happy accident. Exactly. It was looking for bowel pathology. And I guess that's the definition in some quarters of genius, seeing something that's standard and saying, hang on a minute, you know, I can use this for something else. This wasn't my intention, but I can use something else. And this happens with a lot of things in medicine, doesn't it? A lot of drugs, they're made for one thing and they go, hang on. Yeah, like minoxidil. It was made for blood pressure and they realized, hang on, these men are growing their hair back. So now it's used.
Viagra was originally looked at. We did a whole thing on Viagra because of how it's been studied for period pain, but it was originally studied as a heart medication. And then it wasn't very good at that, but it was very good at getting men erections.
Something else. Yeah, exactly.
And if women had been involved in the clinical studies for that, they might have also found that it was pretty effective against menstrual pain, but they weren't. So we are only learning about that now. Yeah. So then this narrative of, now we're learning that men can get endometriosis and now we have tests. It's more about the order in which these things are like coming to the public consciousness rather than like what's actually happening in the research. Okay, that's good to know.
And microRNA is being used, it's really being looked at for various conditions. Endometriosis is just one of them. So it was first noted to be relevant in chronic lymphocytic leukemia. It has a place in certain cancers, for example, and other conditions. So it's just a kind of branch off of that.
Interesting. Yeah. Okay. That makes sense. If you go and get one of these tests and you get a positive and it says, yes, you have endometriosis, what do you do next?
So the role in primary care, the envisioned role of these tests, is in patients who have symptoms of endometriosis. They have imaging, and as we know, imaging does not pick up all endometriosis. If you have a negative ultrasound scan, a negative MRI scan, it does not mean you don't have endometriosis. Yeah?
Right.
However, there are women in which an ultrasound or an MRI scan will pick up obvious endometriosis or adenomyosis. Yeah? So they don't need this test because the imaging has made the diagnosis. But what we don't want is the rest of the women to be like pushed aside. Well, you don't have it because your scans are no. Okay.
Which is what happens so often is you get an ultrasound, you get an MRI, they say no.
Yeah. And that's why this is a game changer. So do they end up waiting however long for laparoscopy only to perhaps not even have endometriosis after they've gone through all of this? Or can we give a really quick, accurate test to say, yes, you do have endometriosis. These are your choices, X, Y, Z, hormonal treatment, Mirena coil, Linzagalix, Ryco, whatever the case may be. Because there are new oral medications which have been licensed for endometriosis as well on the NHS last year. So that's a
Can you
happy
talk
marriage.
a little bit about those last two you said are unfamiliar to me? Can you go into those a little bit?
So they are gonadotropin releasing hormone antagonists. So you will, I'm pretty sure, will have heard of Prostap, Solidex.
No.
Okay. So they
might have different names here. I'm not sure.
They might have different names. Exactly. Okay. So let's wheel back. The pituitary gland in your brain produces the hormones FSH and LH, which drive your ovaries to mature eggs and produce estrogen, and then you ovulate and you have progesterone. We know that endometriosis thrives on hormones. We know this, don't we?
Right. Yes.
Okay.
Yes.
So the GnRH antagonists, what they do is basically they block the receptors so that your pituitary gland does not say ovaries wake up and produce estrogen. So it switches off the ovaries, basically. The long and short of it is they switch off your ovaries, so there's no hormones. So it puts you in this therapeutic fake menopause.
Yes. Okay. We do have medications here. Those are pretty serious, right? My impression of those is that it puts you in basically early menopause or medical menopause.
Reversible though. Yeah, reversible.
Yes. And you're not supposed to be on them for longer than a few months, right?
So the original ones, the agonists kind of work similarly. But yes, you should not be on them for longer than 6 months without hormonal add back. Okay? Because they can thin your bones and you end up with osteoporosis, etc., like the real menopause, right? You can have them for 6 months. So the original ones that you've probably heard of are by injections. Yeah.
Okay.
And you can have them for 6 months and then you can carry on with them if you want, but we need to give you a little bit of hormones or HRT to protect your bones, etc. Okay.
And then is there concern about like the adding the hormones back in could exacerbate the endometriosis?
Well, the idea is that we switch off the ovaries completely and then we add a little bit in so that the little bit is enough to protect your bones, but it's not enough to stimulate the endometriosis. That's the idea behind it.
Okay, thank you.
Last year, 2 new drugs were approved by NICE in the UK, and these are oral, so they're tablets that work similarly. Yeah.
Oh, okay. So they're easier. You don't have to go to the doctor's office. You can take them.
And have an injection every month or every 3 months. Exactly. Yeah. Absolutely. One contains both things. So one, called Ryco, contains both the switch off, we'll call it the switch off drug. Yes. Okay. Relugurix. And it also has an estrogen and a progesterone in for the bone and womb lining protection, etc. in one tablet that you take one a day every day. And the second, Linsagalix or Ucelty, just has a switch-off drug so that you can take that for 6 months, like you said.
Yeah.
And then you need to have separate add-back HRT. So some women may say, okay, I know I've got it. I'll try the medical management because it can be really effective. Yeah.
Right.
They're also, by the way, just for completeness, they also are licensed for treatment of uterine fibroids. That's another story. But anyhow, same principle. Fibroids thrive.
A lot of people have both. A lot of people have both.
Exactly. So you have the test, so contraceptive pill, whatever, if you want. Myrenocol is another option, or surgery. And some people, it just gives women flexibility as well. You might say, okay, I'll have surgery whenever, not right now. I've just started a new job, whatever. Not keen to go for an operation right now. I'll have medical management and then reassess things further down the track because you don't need the operation to make the diagnosis. That's the key fact.
And an operation. So many people are told that laparoscopic, minimally invasive surgery, it's like, oh, you need 72 hours, you need a week. And it's like, no, it's major surgery. You're getting stuff cut out of your organs. For some people, they seem to be able to bounce back very quickly, and some people aren't able to bounce back. I just get so annoyed when people are told, like, yeah, go get your excision surgery. You'll be fine. Just take 2 days off of work. You'll be fine. And it's like, maybe, but not necessarily.
Maybe not.
It is a big deal. It's major surgery, even if it's minimally invasive.
A straightforward, easy operation is a diagnosis of retrospect after you've done it. You could say, straightforward, but you can never know in advance. Yeah,
exactly.
So it's not to scare people from surgery, but it's got to be given the weight and gravity that it needs, really, and seriousness.
Yes, absolutely. The more options, the better, because every person's situation is so individual. They have so many different lifestyle considerations, so many different functions that they need to be able to do. So, like, the more options, the better, and to make sure that everybody knows what their options are and to have as many options available. So they can make the best decision for themselves. Yes. Okay, is there anything else that we should know about these tests?
I've just got to give another plug for the adolescents. I see so many teenagers, like hundreds every year, who have significant pelvic pain, heavy periods, etc. And it can be really difficult to know, is this endometriosis or something else, or just heavy, painful periods of adolescence. It can be really difficult to know. With teenagers, it's even more challenging to make the diagnosis because they're less likely to have endometriomas. They're less likely to have nodules. They're less likely to have deep infiltrating endometriosis. So they're far more likely to have a normal scan. Yeah. The other thing is in teenagers, we don't have in my view, like I say, I'm an adolescent gynecologist, we don't do internal examinations, and that gives us so much information in adult women where we've had pelvic tenderness. Can we feel a nodule behind the uterus, behind the cervix? We can't do that in a 15-year-old, can we? No. And it's probably the population that we least want to operate on unnecessarily.
Right. Yeah,
because we also know that the younger the age at your first laparoscopy, the more laparoscopies you tend to have. And I have seen 21-year-olds who have had 5 laparoscopies. It's
Oh my
crazy
God.
because they've started so young. And then there's, of course, the risk of recurrence. So even if they do have endometriosis, there's also, and life is long, and they're 15, they're 16,
Yeah.
whatever the case may be. Life is long.
Yeah.
I think in this group, it's particularly really useful. And they're the group that I think are most likely to be told, you'll grow out of it. You'll grow out of it. I'm not growing out missing my exams. That is following me for the rest of my life. Do you know what I mean?
Yeah. When I was 14 and I went to my first pelvic exam in order to ask about my periods that were making me throw up, that were just making me pass out, they did do a manual, like a physical exam. And she said, everything looks normal, which looking back, it's like, how do you know? You don't know if everything looks normal just from looking with a speculum. You don't know.
Yeah.
And then she said, everything looks normal. Some women just get bad periods. It will probably go away when you have your first baby.
Yeah. I hear that a lot. I have to say, because, and I think a really instructive time was when we had I don't know if I'm allowed to say COVID pandemic.
You're allowed to say.
Okay, we're over that, are we?
Allowed to say
Okay,
that.
so when we had that, we stopped all gynecology. Yeah, like loads of people stop everything except looking after these really sick patients in A&E, ICU.
Yeah.
And so therefore, my adolescent gynecology clinic just stopped for a whole year. Could not see these
Wow.
girls. Yeah.
Yeah.
So then you build the enormous waiting list of girls who are waiting to see you, plus another year of other girls. So basically, a girl who was referred at age 15 was seeing me when she was 17.
Oh, wow.
Age 14 was seeing me when she was 16. Yeah.
Yeah.
And what was really instructive is that the girl would come in and I'd introduce myself. I'm Dr. Busby, blah, blah, and confirm who you are, that kind of thing. And I'd say, why have you come to see me today? Which is how I always open the consultation. Why have you come to see me today? And the girl and her parents would go, we have no idea. Sorry. We don't know. I'm fine. I'm like, okay, let's have a look. Your GP's letter says that you're having really severe debilitating periods and you can't do anything because of these periods. I go, yeah, forgot about that. You're fine now.
Oh, wow.
And the only thing that happened was the passage of time. And loads of girls just cancelled the appointments because they were fine. Those that came, some still came and still had pain. Yeah, absolutely.
Yeah.
But a significant proportion, it just went. It's adolescence is a time of biggest change in a woman, certainly men too, but I'm a gynecologist, in a woman's life. And there's so much going on, growth, development, etc., that it can be part and parcel of adolescence. So what we don't want to do is go laparoscoping all these girls.
Yes.
Yeah, who it would have sorted itself out. We support them otherwise. Negative endoshow test. Okay, let's not do a laparoscopy. Let's treat you alternatively. Let's check you don't have Crohn's. And that's the other thing. I've laparoscoped girls who have ended up with either severe constipation that they weren't aware of. That was the cause of their pain, Crohn's disease. So it's just about, they could have avoided laparoscopy if we could have had the heads up about that.
Yeah, and it's such a line to walk, right? You don't want to do too intense treatment too soon, and you don't want to just say, oh, it's just adolescent bad periods, it's nothing.
Exactly.
They're like, oh, okay, that's normal. And then they just continue to be in debilitating pain while their endo ravages their body unchecked.
Precisely. Yeah, try this, try the pill, try the coil, try the other pill, because we don't operate on you because you're only 15, you know?
Yeah. Now we can at least know what we're dealing with, even if we're not going in there yet. Yeah. Amazing.
And for so much of them, they cry. They cry with joy. Finally an answer. And okay, and now let's discuss what your options are. And they might still go for the pill. They might still go for the coil, but they're going for it in the knowledge of what they've got.
And that makes such a huge difference. There's been so much backlash against hormonal birth control, at least here in the States. There's been a lot of people saying no one should be on birth control. It's unnatural. You should be in touch with your hormones. You should know your cycles, all of this. And I understand that because I am mad that every time I went to the doctor for my severe period pain and I said, hey, I'm throwing up every time I get my period. I'm passing out. I have to go to the ER. What is going on? What is happening to me? They would say, you can take birth control. And then I tried a bunch of different birth controls and the side effects were tanking my quality of life to the point where I was like, I would rather throw up once a month. And there was never another option given to me to treat my pain. That was the only option. It felt very dismissive and very limited. And so I understand the anger and the like rejection of birth control when it is falsely the only option given to you. I get that. But also it is such an important tool in the toolbox. It's just not the only tool in the toolbox.
Precisely. Absolutely. Yeah. And it may not be a permanent tool. It may be to tide you over until such time as you want an operation or whatever the case may be. Yeah. And we still don't know what's out there and what's to come.
Yeah.
You know? That's the other thing.
That's very exciting because it feels like the next step is we're going to find a cure, right? We're going to figure out a cure. Yeah.
I'm on that train. Absolutely.
We have a lot of people listening to this who are parents of either people who are going to get their periods soon or people who have their periods and are struggling with period pain. And they are trying to figure out the best way to move forward. Is this endometriosis? If so, what do we do? How do we find out? What advice do you have for parents who are listening and are concerned about their child's painful periods?
Don't dismiss it. Don't ignore it. As we've said, yeah, heavy painful periods are common in adolescence. But when your periods are that heavy or that painful that you are unable to function as you would like to, go to school, write exams, play sport, go out with your friends, you're in bed for 2 to 5 days every month, that's not normal. That's not normal. It's abnormal and it needs investigation. I see a lot of women with teenagers who the mother has had endometriosis.
Right.
Or there's a strong family history. Yeah, it's more likely that your child either has or will get endometriosis. And that again is does she have it? She may get it when she's 20. Does she have it now? There too, the tests come into their own really. But I'd say go along, get advice, get imaging as necessary. And there are ways of controlling the pain. There are ways of controlling bleeding, both non-hormonal and hormonal. Tranexamic acid is really effective in adolescents. Mefenamic acid, don't know what it's called.
I think it's called the same.
So there are things that can be done to improve quality of life. But if you have a gut feeling, no pun intended, that this is endometriosis, then chase it, follow it up.
Okay, thank you so much, Dr. Busby. I've learned so much from this conversation on a number of different levels, but it has also made me really excited for the future, which is not a feeling I always get when I do these episodes.
Well, I'm glad to be the bearer of good news.
This is really exciting. It's hard to keep these two opposite things straight in our heads at the same time, which is, one, we happen to be living at the best possible time in history. Yeah. If we have endometriosis, wow, we're so lucky to be alive right now. And also, women's health is decades behind in research and development. And we were raised with this idea that it's all equal. Doctors know best. You just listen to your doctor. And we are learning, actually, so much clinical advice that is given to us has not actually been tested on women's bodies. So many conditions that affect women more than men have been under-researched and less studied. And so there's less information and less options available to us. And that is infuriating and so unfair and so devastating to learn and understand when we have been told our whole lives that everything's equal and that the doctor has the answer for us. And so both things are true at the same time. There is...
Yeah. I'm an optimist and I think things are on the up. And things are on the up largely due to patients speaking up, women speaking up, advocating for themselves and other women. So all I can say is keep up the good work. And you can't keep a good woman down. Yeah, so we won't be silenced.
As much as they try.
I have a feeling that the tables are turning and it'll be loads of research, loads of funding going into women's healthcare. But I've got to believe that as a gynecologist, haven't I?
Yeah, otherwise, what are we going to do? Be upset all the time?
What are we going to do?
Yeah.
Exactly. Exactly.
Where can people find you if they're in the UK and they want to see you as a doctor? Are you on social media or do you have a place people can go to follow you?
Yeah, so Instagram, Dr. Gail Busby. Facebook, Dr. Gail Busby. TikTok, Dr. Gail Busby.
Okay, I'll put the Instagram in the show notes so people can follow from there. Great.
Perfect.
Thank you
Excellent.
so much, Dr. Gail Busby. This has been so informative for me and also just a delight talking to you. And it makes me feel excited about the future.
Same here.
That's it for this week's episode. Head to the show notes for a link to Dr. Gail Busby's Instagram, as well as a couple of articles and reports about these tests if you want to know more. And hey, while you're in those show notes, click on over to the CRAMPED Patreon and support this work. These episodes take between 5 and 20 hours each for me to make from beginning to end, depending on how much research I do. And it's just me over here, trying to make this my full-time paying job. So if these episodes are worth $5, $10, or $25 a month to you, it would genuinely make a huge difference if you would click on over and join a paying tier. If you are not financially able to support the show right now, that's okay. Here's a couple of totally free things that would also be incredibly helpful. Whatever platform you're listening to Cramped on right now, whether that's Apple Podcasts, Spotify, Pocket Casts, Amazon Music, any of them, go give Cramped a 5-star review. That genuinely helps the algorithms on these platforms pick us up. Another completely free thing to do that only takes a couple seconds is go into our show notes and click on our sponsor links. Our sponsors check how many people are clicking those links, and the more people click it, the more likely those sponsors will stay with us another month or two. And of course, as always, tell a friend about the show or post about it on social media. Thank you for doing these things. I'm so glad you're here. See you next time, Crampers.
What's happening to your body, we don't know, 'cause we've never really studied the female body.